Good afternoon, and thank you for joining us. My name is Dr. Shalini Aranagiri, and I'm Deputy Clinical Director here at Turning Point. It's a pleasure to welcome you today to today's Talking Point session on testing new medications for methamphetamine use disorder in young people. Today, our Talking Point session will be presented by Associate Professor Julinda Betty and Dr. Alexander Guerin. Before we get started, just start with the welcome to country. Just wanted to begin today by acknowledging the traditional owners of the land on which we meet today and pay my respects to their elders past, present and emerging. Would like to extend that respect to Aboriginal and Torres Strait Islander peoples here today. For a bit of housekeeping before we start, we have a large audience today, and so please ensure you're muted and your video stays off during the presentation. Just as a reminder, the chat function is disabled in this platform, as well as the raised hand function. If you do wish to ask questions, please pop that in the Q&A, and we'll keep questions to the end of the presentation, and there'll be ample time to have that answered. So to start with, let me introduce you to our two speakers for today. I'm joined first by Associate Professor Julinda Betty, who's Head of Substance Use Research at Orygen and Principal Research Fellow of Addiction and Youth Mental Health at the Centre for Youth Mental Health at the University of Melbourne. She completed graduate training in clinical psychology at Monash University and postdoctoral research at the University of Chicago. Until 2017, she was a faculty member in the Division on Substance Use Disorders at Columbia University Medical Center and at the New York State Psychiatric Institute in New York City. Jill returned to Australia in 2017 to lead the development of a youth-focused clinical drug and alcohol research program at Orygen. Her research focuses on early intervention and new treatments for substance use problems in young people and the neurobiological mechanisms underlying the development of substance use disorders. She uses a range of research methods, including clinical trials, human behavioral pharmacology, and neuroimaging and MRI. Also joining Jill today is Dr. Alexander Guerin, who recently completed his PhD at the Florey Institute of Neuroscience and Mental Health and the University of Melbourne. Under the supervision of Associate Professor Ji Hyun Kim, he investigated risk factors associated with early onset methamphetamine use in people with methamphetamine use disorder. He has since joined Orygen's Substance Use Research Group, led by Jill Betty, and is currently the project manager on a suite of clinical trials investigating novel pharmacotherapies to treat methamphetamine use disorder in young people. It's my pleasure to introduce Jill and Alex, and I'm going to throw over to them now.
Thanks, Shalini, and thank you all for coming. It's a pleasure to be here. I'm just going to change this. Oh no, now it's just Shalini. That wasn't supposed to happen. Okay, so I am going to be presenting a bit of an introduction to the talk today, and then we'll go through a couple of studies that we're working on at the moment in my group. So just in terms of our this stream of our research, which focuses on methamphetamine use in young people. So despite coverage in the media, we know that that overall methamphetamine use in Australia has actually been going down since 2001. However, at the same time, we've seen use of crystalline methamphetamine or ice increase. And crystal methamphetamine or ice is typically administered via the IV or smoked routes, which leads to a rapid onset of effects, which of course is a key determinant of the abuse liability of a substance. So what we see is that despite the overall methamphetamine use going down, there is an increase in stimulant use disorder rates and related harms over the past few years in Australia. This has actually been paralleled in other countries, including the USA, where there has been an increase in methamphetamine use and harms since 2005. Okay, in Australia, we have rates of past year use of methamphetamine at around 1.3% of 14-plus-year-olds. Young adults between 20 and 29-year-olds have the highest prevalence of methamphetamine use in Australia. The average age of people who use methamphetamine, the average age of onset is a median of 20 and a mean of 22. And 20 to 29-year-olds, as I said, are the age group most likely to have used in the past year, with 2.4% prevalence of past year use. And that's from the 2019 National Drug Strategy Household Survey. So this is just, I guess, a bit of a background on our focus in my group on substance use in young people. So we know that despite the fact that most people do not show up to treatment until they're a little bit later, Substance use typically starts in adolescence with the peak onset of substance use disorders occurring between 18 and 20 years old. There's some data suggesting that outcomes are improved by early treatment, although there is some data suggesting that age and length of use may be a factor in determining treatment outcome as well. However, in common with mental health conditions more broadly, we are focused on the idea that intervention at the earliest possible stage is likely to both improve likely outcomes from treatment, but also stop some of the functional issues that happen that are associated with substance use during adolescence and early adulthood, which, as we all know, is a very important period for developmental trajectory overall. So that's the focus of our group, is on early intervention and also treatments for young people with emerging and existing substance use problems. So before we started this research program, one of the things that we really wanted to establish is whether or not young people actually present for methamphetamine use problems in the Australian and Victorian Drug and Alcohol Youth Focused Service System. So on the left here, we have data from the YSAS Youth Needs Census, which is Victorian, from 2018. It's actually data collected in 2016. And what we see is that while obviously cannabis is the substance most commonly associated with entry into treatment, young people who use methamphetamines do present into treatment, and it's around about the third most common reason for presentation into treatment across treatment types, with the most common presentation for, perhaps unsurprisingly, residential withdrawal services. And on the right, we just have this is a single service number of episodes of care with primary drug of concern from 2019 to 20. And again, we see that cannabinoids and cannabis are the most common reason for presentation, but amphetamines are the third reason. So in answer to our initial question, yes, young people do present for methamphetamine use problems in the alcohol and drug use service system. So I'm going to pass over to Alex now to talk about one of our studies.
So as Jill said, in the group, we're very interested in substance use disorder and methamphetamine use disorders. And we're specifically interested in testing new medications to reduce substance use disorders. So for opioid, alcohol, and nicotine use disorders, medications form a very key part of the treatment. However, it's important to know that best practice for treatment of substance use disorders is to combine both pharmacotherapy and psychosocial therapies. At the moment, there's no efficacious medications to treat methamphetamine use disorder, and medications are clearly needed to bolster the effects of psychosocial treatments in this particular population. So this brings me to the two studies we are currently running. So we are running 2 clinical trials at the moment, and we are testing 2 new candidate medication. One of them is ketamine, and the other one is cannabidiol. So I'm going to spend the next few minutes talking to you about the ketamine study, and then I will hand over back to Jill to talk about the cannabidiol. So why ketamine? Ketamine is a non-competitive antagonist of the NMDA receptor. The good thing about ketamine is that it's already well characterized, and it's already used in anesthesia and also in depression in sub-anaesthetic doses. Ketamine potentially normalizes glutamatergic dysregulation in substance use disorders, which in turn may facilitate new learning and therefore improve psychosocial therapies. There's quite a lot of evidence, and very strong evidence, that 1 to 2 intravenous infusions of ketamine combined with psychosocial intervention can improve cocaine and alcohol use outcomes. And I'm just going to spend a bit more time on the cocaine studies in a minute. At the moment, there's no research of ketamine in methamphetamine use. But yeah, let's go back to the cocaine use literature. So this is quite interesting because cocaine and methamphetamine are quite similar. They share similar patterns of use and also similar psychopharmacology. They're both psychostimulants. And the results so far in the cocaine literature is quite remarkable. So there's 2 laboratory studies in non-treatment seeking participants that show that a single intravenous infusion of ketamine can improve the motivation to quit cocaine and also reduce cocaine self-administrations compared to placebo. There is also a more recent clinical trial that showed that a single intravenous infusion of ketamine can improve abstinence, reduce relapse, and reduce craving. So compared to placebo, people in the ketamine group, 48% of people in the ketamine group maintain abstinence in the last 2 weeks of the trial, compared to 10% in the placebo group. They were also 53% less likely to relapse if they were in the ketamine group, and their craving score were 58% lower compared to the placebo group. It should also be noted that this clinical trial used a single infusion of ketamine in combination with a mindfulness-based relapse prevention therapy. Importantly, the ketamine was very well tolerated in this population, and there were no single adverse event-related withdrawal from the study. So this brings me to the first study we want to talk to you about today, and this one is called the MASKOT study, or the methamphetamine use in young people sub-anaesthetic ketamine open-label trial study. So the MASKOT study is funded by an NCRED seed funding grant. MASKOT is an open-label design, which means every participant will receive ketamine. We are currently recruiting 20 young people aged between 15 to 25 years old with moderate to severe methamphetamine use disorder. And recruitment is currently being done via social media and also via AOD services, so referrals directly from AOD services. The primary aim of MASKOT is to test the safety and tolerability of 2 ketamine doses injected subcutaneously 7 days apart in young people with methamphetamine use disorder. We'll be looking at safety by looking at the change from baseline in ketamine use, frequency, and craving at week 6. So we don't want young people to start using ketamine following the ketamine injections. And we also looked at safety by looking at liver function tests at week 2 and investigated if there's any changes in liver chemistry. We'll look at tolerability by looking at the number of participants are withdrawing from the study due to adverse medication effects. The secondary aim of this study is to test the preliminary efficacy of those 2 ketamine doses for methamphetamine use disorder in youth. And we'll be doing that by looking at changes from baseline in methamphetamine use frequency and craving at weeks 2, 3, 4, and 6. And we'll be doing that by using urine toxicology, the timeline follow back, and the brief substance craving scale. We're also very interested in looking at potential mechanisms of the clinical response to ketamine treatment in this population, and also assess potential predictors of the treatment response. So we'll be looking at acute and early ketamine response, and also looking at cognitive function, cognitive control, and impulsivity. So I'm going to spend a bit of time going through the experimental timeline for this trial. So every participant will first be screened as part of a joint screening protocol. So the 2 studies we're going to discuss today will have the same screening session. And at the completion of the screening, participants will be allocated to one of the 2 studies, depending on which one better fits their needs. If a participant is allocated to MASKOT, they will undergo a baseline visit just to ensure they are eligible for the study. Then at day 0, they will undergo their first ketamine infusion, and all the ketamine sessions are being conducted at the Royal Melbourne Hospital Clinical Trials unit. So they will receive their first subcutaneous injections, and then we'll be monitoring the young person for about 4 to 5 hours, and we'll be monitoring the vital sign, look at any ketamine-related side effects by using the ketamine side effects tool. We'll also look at drug effects, any psychotic and dissociative symptoms, and also mysticism using the Hood's mysticism scale. 7 days later, they will undergo their second ketamine session. After each ketamine session, I'll be giving them a very brief phone call to record any adverse events, and they will also go through the ketamine side effects tool. 2 weeks after starting the study, they will undergo the big end of treatment assessment, and that's when we'll be collecting blood to look at liver chemistry and also administer a series of questionnaires. And then there's 3 follow-ups at day 21, 28, and also 42. So let's look a bit more at the ketamine and particularly the doses. So every participant will start at level 1. So in the first session, they will all receive 0.75 milligram per kilogram. At the end of the first session, our study doctor will ask them questions, go through the ketamine side effect tools, and then decide whether the participant tolerated the starting dose. If they did tolerate the starting dose, in their second session, they will go up to level 2, which is 0.9 milligram per kilogram. And if they did not tolerate the starting dose, they will go down to 0.6 milligram per kilogram. Throughout the trial, participants will be required to receive treatment as usual. They will be engaged with a GP, psychiatrist, or addiction medicine specialist throughout the trial, and we'll also be referring them to AOD counseling services. So there's good safety data from depression studies, and also there's currently a depression study in young people, and the ketamine seems to be fairly well tolerated in this population. It should also be noted that the ketamine dosage is fairly low, and we are administering the ketamine subcutaneously. There is a potential for abuse liability with ketamine, and we'll be assessing that throughout the trial by looking at change in ketamine use throughout the trials at every time point. In terms of progress, the study started recruiting in June 2021, last year. However, it was pretty much stopped straight away when Melbourne went back into lockdown. The Royal Melbourne Hospital stopped recruitment for all of their studies. So we were on standby for 3 months, and pretty much everything picked back up around October last year. We have made initial contacts with 15 potential participants, and right now we are engaging youth-focused AOD treatment services to try to increase recruitment. And I will actually go back to recruitment a little bit later in this talk. But for now, I want to hand over back to Jill, who will talk about the second study.
So I'm going to talk about our second study, which is another relatively small open label study that's focused on potential medication for methamphetamine use disorder in young people. And the medication in question is cannabidiol, or CBD. And as most of you would be aware, CBD is a non-intoxicating cannabinoid. It's quite complex substance pharmacologically, and has a wide range of effects. It appears to be anxiolytic. There's some fairly good signals indicating that it is an antipsychotic in populations with psychosis. And there's some evidence it's antidepressant as well. Although there haven't been any studies for methamphetamine use with cannabidiol, there is evidence from a rodent model that it reduces methamphetamine self-administration and also, inverted commas, relapse to methamphetamine use in this rodent model. Similar to ketamine, the mechanisms are not specific to a particular drug type. So we're really focusing on methamphetamine because we think this is an important substance that there are no currently approved medications for. Since we started the study, there's actually been one clinical trial published, which was in cocaine use disorder, and did find that cannabidiol did not reduce cocaine use in the clinical trial. However, there was a couple of reasons that may have been, other than it just not being effective. One is that the study was a little bit underpowered, although there really wasn't any signal at all, so it doesn't seem like it was a power issue. And the second is they actually stopped at a dose that it was a little bit lower than where we're going. And there's some evidence from the rodent model that it was only the highest dose of CBD that actually produced a therapeutic effect. And to date, there's been no clinical trials for methamphetamine use, either in young people or in other populations. So I did just want to note that there are some issues with CBD, and this is more so, I think, in the UK and the US than has so far been the case in Australia. But there is a general sense that CBD can do pretty much everything, including it can cure the coronavirus. I understand my mother-in-law gave it to my dog recently to cure something, I think arthritis. It's in coffee, it's in skin cream, it's in shampoo. So we are conscious of the fact that there are some concerning potential placebo effects around CBD, and some concerning expectancies about this. The use of CBD in this trial is actually quite different from what is being sold over the counter, for instance, which is very low dose CBD and is almost certainly a placebo. The dose that we are using is 800 to 1,000 milligrams. So we can move on from that. Okay, so the study that we're going to be talking about is called the CALM study, Cannabidiol, a novel pharmacotherapy for lowering methamphetamine use. It's again an open label design. This is a smaller study than the MASKOT study. So we aim to recruit 12 young people between 15 and 25 years old with mild to severe methamphetamine use disorder. So compared to ketamine, there's actually less in the way of potential safety concerns from CBD. As I said, it is non-intoxicating. It doesn't have any apparent abuse liability. So we're including young people with mild, moderate and severe methamphetamine use disorder, whereas for the ketamine study, we're only including moderate and severe because there's more risks associated with ketamine administration. And again, we're using the common recruitment pipeline that Alex will be talking about a little bit later. So we're recruiting online and we're also recruiting via youth-focused AOD services. So the primary aim of this study is really, again, to look at safety and tolerability of 8 weeks of treatment with CBD with an initial dose of 800 milligrams titrated to 1,000 milligrams per day. Participants will be taking the medication at night after dinner, so we expect there to be some slightly sedating side effect profile, and so we expect that to be actually a therapeutic effect in terms of sleep in this population. In young people with methamphetamine use disorder. And our main outcome measures for safety is actually liver function tests at week 4 and 8. Although much higher doses of CBD are used in young children for Dravet's seizure disorder, and that's well tolerated, there is a little bit of concerning evidence suggesting that in some populations we might see elevated liver function tests. So that's one of our key markers of safety in this population. And our measure of tolerability will be the number of participants withdrawing due to adverse medication effects. And our secondary aim, as is the case for the MASKOT study, is to assess the preliminary efficacy of 8 weeks of CBD maintenance in this population. And we're going to be looking at change from baseline in methamphetamine use frequency and craving at weeks 4, 8, and 12. So similar little diagram of the study and the process itself. So as noted before, the screening process is a common screening process for both MASKOT and the CALM study. So participants will start 30 days, up to 30 days before they actually start their baseline visit. They'll undergo comprehensive screening to ensure that it's going to be safe for them to participate in the study. Then they will do a baseline visit in which we will capture a range of different measures, including obviously frequency of methamphetamine use at baseline and a range of other psychiatric and functional outcome measures. They'll be visiting weekly to receive their medications or either they will be visiting or we will be visiting. So we do have the capacity to do outreach visits as well. And also to report on their methamphetamine use and provide urine samples for verification. They have a longer assessment visit at weeks 4 and 8, and during those sessions we will have bloods taken to assess liver function tests. And then the final period is, the final assessment is at week 12, and that is 4 weeks after the cessation of CBD. There's some evidence in animal models and also in heroin, people who use heroin, that therapeutic effects of CBD in substance use disorders may actually outlast the period of drug administration. So that's why one of our time points actually is beyond the period of drug administration to see if we can get any signal at that point. So in terms of safety and ethical considerations for this population, so CBD is really very well tolerated in psychiatric populations. We've also used it in populations of people who use substance use and had no issues. It's really pretty clear that it's non-intoxicating with no evidence of abuse liability. It really often is experienced by people as a placebo. As I said, there's one paper that suggests evidence of effects on liver chemistry, which needs further assessment, although the doses we're using, as I said, is much lower than what is used in children for seizure disorder. So that is reassuring. And in terms of our progress for this study, we have, as I said, a common screening and recruitment pipeline with MASKOT. We are currently finalising our ethics approval and governance. We actually have our investigational product, which doesn't seem like a big deal, but actually is a big deal for getting high dose cannabidiol. Is hard to get your hands on at the moment, and also quite expensive. So we're pleased that we have that. Yeah, and that's basically it for CALM. So I'm actually going to hand over now to Alex again to talk a little bit more about our recruitment woes / process. Thank you.
Yeah, so as mentioned several times throughout the talk, every participant is currently being recruited through a joint screening protocol. So participants first make contact with us and then undergo the session, which is about 3 hours in length. And they go through a battery of tests, and then we allocate them to one of the trials and to the trials that best fit their needs. There's another reason why we're going through this joint screening protocol. It's to prevent study entrants to obtain the medication itself. So that's specifically for ketamine, really. We don't want young people to self-refer just to receive medical grade ketamine or medical grade CBD. So when they register for the screening protocol, they are told that we are testing a range of medications for this methamphetamine use. They do the entire protocol, and then depending on which study they meet criteria for, they will be allocated to that study. And then they're obviously told which medication they will be receiving. So as mentioned before, we have made 15 initial contacts with young people. 12 of them were via our social media campaign, and 3 of them were referred from youth AUD services. Unfortunately, out of those 15 people, 7 of them failed pre-screening. So I've given them a call, and unfortunately they were not eligible. So 2 were no longer interested in receiving treatment when I made contact with them. 2 of them were not aged 15 to 25. They were too old to take part in the study. 1 of them had another substance use disorder. So we exclude 4 people with moderate to severe substance use disorders, and except for cannabis and nicotine use disorders. But yes, this person unfortunately met criteria for a severe GHB use disorder. And 2 other young people were currently taking exclusionary medication. So they were both on antipsychotic, which may interact with the study medication. 4 of those expression of interest could not be contacted. So I tried to call them, text them, email them, but I could never get onto them. The good news is that 2 potential participants passed the pre-screening over the phone. One of the participants was booked for the consent/screening session, but unfortunately did not attend. And another one is currently booked for this coming Friday. So this is very exciting because she might be our first participant. We also have 2 other clients that have expressed interest, and I have sent them the PICF and also more information about the studies, but they have requested some time to think about it before committing to anything. So now I want to spend the next few minutes talking about the challenges we have been facing recruitment-wise. So the first one, and one of the biggest one, is COVID. So it's affected everyone, and it really did affect the startup of those 2 studies, but also recruitment. So as previously mentioned, the Royal Melbourne Hospital actually suspended all their clinical trials last year. So it was very unfortunate because it was right after we had started recruitment. So we had to stop pretty quickly after starting. We are back to recruiting now, though. Another challenge is that we actually received very little interest from our social media campaign, and that was quite surprising to us because we modeled this campaign on previously successful campaigns from other clinical trials in people with methamphetamine disorder, or even things I did during my PhD that seemed to work fairly well then. The ad campaign was run on Facebook and Instagram. So there has been some changes to the policies, and you can no longer target ads for people under the ages of 18. So that could maybe explain why we didn't get as much interest, but that should still leave people 18 to 25 anyway. Another thing that we discussed a lot is, do young people still use Instagram and Facebook? It's possible they have moved on to other social media platforms and therefore did not see any of our posts. So we did investigate other social media platforms, and we looked into Snapchat and TikTok. Snapchat straight up said, no, they're not allowed to advertise clinical trials. And TikTok was really, really expensive. We were looking at about $5,000 for a 2-week campaign. And the problem is it wasn't very specific. They only advertised Victoria-wide. And we're more interested in recruiting around the greater Melbourne area. So we did recently start a new social media campaign. And this time we tried to target specific LGAs and suburbs. And to do this, we actually looked through the AOD Stats website that is powered by Turning Point. And we looked at direct line data. So we looked at where the calls about methamphetamines are coming from in Melbourne, and we targeted those specific suburbs, in addition to suburbs around the headspace centres operated by Origin and also Origin Parkville. Another challenge is the fact that very few expression of interest led to actual interest for the study. So usually I would receive an expression of interest and try to contact the young person pretty much immediately. And what I find very interesting is that even within the span of a few hours, so between sending the expression of interest and me contacting them, the young person would have already changed their mind and not want to reduce their methamphetamine use or not want to take part in the trial anymore. So there seemed to be some sort of ambivalence about receiving treatment, which I find quite interesting. And what we're doing now is we're trying to understand why are young people not interested? Is it that they're not interested in receiving treatment, or they're just not interested in doing clinical trials? They don't have time, they don't want to. Lastly, it is possible that methamphetamine use is actually on a downward trend in this particular population. So we know that we have recently started a collaboration with Western Health Drug Health Services. And most of the young people they see actually seek treatment for cannabis and Xanax use. So there's actually not as many people use methamphetamine as before. But now I want to finish this talk by talking about potential solutions and things we have been doing to try to improve recruitment. So we have been targeting youth AOD treatment services directly, and that's based on the fact that clients might be more likely to take part in the study if they're already seeking and receiving treatment as opposed to being from the community. So we have started a formal partnership with the Western Health Drug Health Services Adolescent Community Program, and Dr. John Cook at Western Health has joined our study team as site principal investigator at Western Health. They see about 100 young people use methamphetamine every year, and we have started recruiting from the services at the end of last year. To date, we received 3 referrals from their services. One young person who was eligible but did not turn up to her appointment, and another person who was eligible, but I've never been able to contact her again. So hopefully I can get onto her. We are currently trying to expand within Western Health as well, and looking at recruiting from the withdrawal unit and also through their AOD worker at their emergency department. In addition to Western Health, we've been looking at other youth AOD treatment services, including YSAS. So Jill already has a pretty good relationship with YSAS. They have a partnership on another project, and we've been contacting them. So YSAS, Abbotsford and Preston. And we're going to be working together to see if we can identify young people in their services. And we've also been in touch with Regen, who currently provides AOD care for some of the Origin-led headspace centres. We've also gone around the other AOD treatment services, so not specifically youth services. We've made contact with St. Vincent's Hospital, Melbourne Department of Addiction Medicine. And we also have Shalini here at Turning Point, who's an investigator on 2 studies, who is helping us with recruitment. So in summary, pharmacotherapies for methamphetamine problems are clearly needed. And it's very important to intervene in young people to reduce long-term impacts of methamphetamine use. Ketamine and cannabidiol are 2 very promising candidates that we are currently testing. However, we have some recruitment challenges, and I'm sure Jill can talk a bit more about this, but we would like to hear your thoughts about recruitment and see if you have any suggestions or if there's anything you can do to help with recruitment. And I just want to finish by flashing the study email if there are any clinicians here, and if you see a young person that you think might benefit from joining research study to reduce their methamphetamine use, feel free to shoot me an email on this email address, and we can see what we can do. Thank you.
Thanks so much, Alex, and thanks, Jill, as well. I might invite you both back to answer a bunch of questions from our audience, and we've got some really good good questions from the audience for us to kind of work our way through. I guess to start with, they're both really interesting sort of investigational drugs in these trials, and I guess some of the questions that are coming through relate to the substances themselves. One of the questions around the CALM study in CBD is a question around whether the CBD is in what capacity it is in terms of the quantity of THC or other cannabinoids that might be included in some trials of cannabis substances. So I wonder if Jill and Alex, you want to be able to speak to the product that's been trialed and what that content of that product actually is.
Yes, that's a great question. And a lot of what is being sold, commercial products, is actually would be less concerned about it having other cannabinoids and more concerned about it not having any cannabinoids in it. So that is very correct, that there's poor levels of oversight and purity of the product. We're actually getting our product from it's a GMP product that's being manufactured in Austria by a pharmaceutical company that is essentially focusing on this. We have used the product before, so all of the testing that happens is exactly the same that would happen for any pharmaceutical product, basically. Which doesn't happen for things that are sold over the counter as health products, or the way that CBD is generally being sold over the counter. So we don't have any concerns about the purity of it because of the manufacturing processes. We've also used this manufacturer for a previous study, and whilst the CBD was not directly tested, the urine was tested for CBD levels, and there was no evidence of cannabinoids other than CBD. So we feel pretty confident about the fact that we're getting CBD and we're getting the dose that we expect. So that is good.
And I guess with the other study looking at ketamine, as Alex mentioned, there is abuse liability associated with ketamine. There is a common question from the audience in relation to, I guess, the ketamine in the trial, but also potential use of ketamine outside of the trial by participants. Is there any way to sort of measure or account for that? Is there any process in the study to think about ketamine use outside of the trial?
So it's a great question, and it's something that we've really thought about quite a lot because of the risks associated with this. One of the primary outcomes for the study is actually how much people are using of ketamine before and after the trial. So what we do not want to see is people start using ketamine or increase their use of ketamine over the study. Whereas our parallel study that's being run through Origin, looking at ketamine for depression in young people, actually excludes people who have any use of ketamine. We didn't feel that that would be viable in this study, given the population and the known polydrug use of the population. So what we've done is we're excluding people with ketamine use disorder. So people who have essentially existing problems with ketamine use, we won't bring them into the study. But in terms of actually controlling for the possibility of study participants accessing extra doses outside of the study, I guess there's two things we want to be concerned about. One is we want to make sure that people know that we're measuring that, and we feel unconcerned about actually providing that information to us. So we will be asking about their drug use more generally. And we have a range of ways to do that in a way that sort of allows people to actually tell us that information. The other thing is the concern that participants might suddenly go, oh, this really worked for me and made me feel a lot better, and now I'm going to go and do it outside of the study. And that's something we've also thought about a little bit, quite a lot as well. And so part of our processes is really, and part of our debriefing processes is really around emphasising to people that The ketamine that they're receiving in the study is not the same as what they would be buying in this, on the street, and that there's no evidence that ketamine use in a recreational kind of way does anything that is positive at all, as opposed to it being used in a medical setting. But the short version is this is one of our questions of interest, essentially, around safety. Can this be done? Can we administer it in a medicinal setting without producing these kinds of problems in the broader community? So
I think that kind of relates to some questions around recruitment and who we're aiming to recruit for both those studies. Lots of really useful suggestions and lots of really useful context as well in the Q&A. So thank you for everyone's participation and popping that through. I might go through some of the questions around clarifying the recruitment process. So a few questions have come through about whether rural or regional participants might be eligible. Can you guys speak to that at all?
So that's something we actually considered, because obviously there are higher rates of methamphetamine use in rural populations. The problem we have is it will be difficult for us with our resources to actually go out to see people in rural settings. We wouldn't say it's not possible, but it would really depend where they are. And also it would depend which study they were in. So we need people, particularly for the ketamine study, they need to be able to come into the Royal Melbourne for the sessions. And for the other studies, at least during screening, we need to see them at Parkville, and then from there we might be able to consider. So definitely, if it's sort of within the an hour or two from Melbourne, I would definitely consider referring the person, and we can kind of deal with it on a case-by-case basis.
And I think the other question too about eligibility criteria, I think you both kind of answered some of this, but just reiterating in terms of the exclusion around polysubstance use.
Yes, so we, again, recognising that this group is not polysubstance use, we had to really balance our reason for limiting it in some ways was around safety. So we felt we were concerned particularly around things that would produce a clinically significant withdrawal syndrome. So Xanax, GHB, alcohol. We were really concerned because we actually require people to not use for I think it's 24-hour period before the ketamine sessions, particularly. And so we didn't want to bring anyone into the study where there might be concerns that not using would actually cause a dangerous response. So for that reason, we've excluded anyone with severe to moderate to severe substance use disorder on anything that isn't methamphetamine, cannabis, or nicotine. But they still can have use in that population, as we expect them to be drinking alcohol and using a range of other things. It's just whether they meet those more severe use criteria.
In terms of meth use itself, if people are actually already abstinent but at high risk of relapse, would that person be considered at all?
So without going into too many details about the process, we encourage people to send people who would be in that position. And in some cases, they will meet criteria. In some cases, they won't. But what we're doing, and again, it's not optimal because obviously we don't want to just kind of wait until people relapse, but we're basically keeping contact with people whether we feel that they might not quite meet the criteria, but that there's a possibility they will in the next month or two. We'll sort of keep contact with them.
I guess similarly, a question about clinicians who might be seeing clients who are in counselling currently. Would they be able to participate?
Totally. Yeah. Anything other than, if they're in resi rehab, obviously that's not going to work. Even people who are in detox, we know a lot of people coming out of detox won't maintain abstinence. So it really depends on the study, the specific requirements of the study, because as I said, the different ketamine and CBD have different risk profiles associated with them. But definitely, I guess the message we'd like to put out is if you have anyone who seems like they would be interested and you think they might meet criteria, we'd really love you to refer them so that we can at least do the screening with them. And the other thing I was actually just going to say is that for some young people who do the screening, Firstly, they will actually get reimbursed for their time financially. So we have payment for the research sessions, and someone completing the entire ketamine study will be paid over a series of sessions around $400. So we are recognising the fact that young people are giving up their time for this. But the other thing is that we also have a quasi-control group, which will be people who essentially don't quite meet the criteria for the main study. And so it's possible we'll be able to offer them something that would be a bit of extra cash and would be participation in research as well, even if they don't exactly meet the criteria.
Sounds like if clinicians are seeing anyone at all, when in doubt, just refer them through to that email address. Yeah. Great. And just a few questions coming through too about social media recruitment methods and some creative license there. I think there's some questions around whether other types of social media have been considered, including addiction subreddits as well, whether we've tried Reddit as an option, Alex.
So we haven't tried Reddit itself, but we have posted on some addiction. Well, some people have posted on our behalf on drug use forums that didn't really amount to anything. We tried a lot of different things. We tried dating apps as well. Tried Snapchat, TikTok, Gumtree. Yes.
Yes. Yeah. So I think it's really helpful that people have kind of popped into the chat to some of the services that they're working at. And I think what we'll look at too, some of the registrants have asked if we can send some information out with the recruitment flyers to the participants in today's seminar. And I think that will definitely be something we can send out so that if you're a clinician that's here today, you'll have that information in front of you and you can send that stuff straight through. I think another question around recruitment is whether we've had an opportunity, I suppose, to test out snowball recruitment.
We haven't had anyone in yet, so we haven't had the opportunity to test out snowball. I don't think we don't have it formally written into our protocol, but we would definitely encourage, and I know Alex has done this in his previous work with this population. Did you want to comment on that, Alex?
Yeah, so the main issue for this is that we actually haven't seen anyone in person yet. So yeah, but it's definitely something to consider. And we have flyers, participant-facing flyers that the participant could definitely take home and share it with friends and families or other contacts. So that's once we actually get people in, that's definitely something we'll consider.
I guess to kind of drawing this to a close, I think there's been a lot of interest in the innovation that these two trials are bringing to drug and alcohol research more broadly, both for young people, but also just broadly for methamphetamine use and substance use in general. There's some questions around how this relates perhaps to the use of ketamine for depression and ketamine microdosing trials. I don't know if either of you want to comment on that and how that's influenced, I guess, some of the thinking in this space.
Yeah, so I won't comment on the microdosing trials because I'm actually not familiar with microdosing with ketamine, and my sense of the microdosing literature more broadly is that it's really showing up a placebo kind of profile, which is unfortunate. But the ketamine for depression is definitely something obviously that we've been quite interested in. So one of our collaborators, Colin Liu, is really a leader in Australia in the use of ketamine for depression and is a co-investigator on this study, but also on the SKY-D study, which is testing ketamine for depression in young people. So we're definitely informed by that. And one thing actually we didn't mention for either of our studies is that both of these medications have the potential to treat common comorbidities in this population as well. So one of the nice things about this is that we obviously know that depression is very highly comorbid with methamphetamine use, as is psychotic-like symptoms. So we know that psychotic-like symptoms seem to be improved by CBD, and ketamine obviously seems to have an antidepressant profile as well. So one of the things that we think make both of these options quite promising. I guess in terms of we are framing our study a little bit both from the literature on ketamine for cocaine use disorder, but also around some of the way that ketamine has been used for depression, particularly in terms of there being isolated doses that in this study it's 2 doses. But for the ketamine depression study that we're involved with as well, it's 4 doses. And we think this is an empirical question of really how many doses do you need and in what combination with psychotherapy, like what's the optimal kind of treatment process that people would go through. My sense is that probably for substance use, it's a little bit different for depression. And rather than an ongoing treatment, it's going to act as a bit more of a fast track for people to engage in evidence-based psychotherapy. So we might see something like an inpatient period with 2 doses of ketamine at the beginning of a week and at the end of a week, with an intensive psychotherapy process during that inpatient period, followed by a follow-up period for 6 to 8 weeks afterwards with more psychotherapy built in. So it remains an empirical question, but I think we have definitely drawn on the depression literature to answer some of these questions.
I guess on that point as well for both of these studies, could we speak a bit to the psychotherapeutic support or counselling support that might be available during these studies?
Yeah, so these studies, and this is one of the reasons that we have, so we don't actually have a dedicated AOD treatment pipeline at Origin. So for a lot of our other studies, we recruit people directly from our clinical services, and then we share clinical governance and research governance within the same organisation. For this study, because both of them are funded as small pilot studies, we don't have the capacity to provide a behavioural platform as well. And that's why apart from the fact that it's open label, the efficacy data will be very preliminary, because certainly in the case of ketamine, we have reason to believe that it's actually going to be the combination of ketamine and psychotherapy that produces an effect, as opposed to just ketamine by itself. So for these 2 studies, we are not providing any psychotherapeutic support, and clinical governance is actually going to be covered by the participants' medical doctor, so either their GP, and that's because they're short studies. We want to make sure that at the end of it, they've still got coverage for their clinical needs. We do have medical support for the study, and they're going to be assessed by a registrar at baseline, and they'll also be seen at various points throughout the study. But the clinical coverage is going to remain in the community, essentially. And we will also provide, if people are not already engaged with AOD counsellors, we'll also provide referrals and encourage them into treatment. If we get a good sample and have a good feasibility sample for these studies, which so far, feasibility signal for these studies, which so far we have not had, we will definitely think about in larger projects having more comprehensive involvement of behavioural support as well.
It sounds very much like these 2 studies are, at that pointy end, and hopefully will lead to more sort of larger opportunities for research in this area. And I think before we sort of wrap up, I was wondering, Alex, if you can go back to the slide with the email address. I think there's a few keen people in the audience who just want to refer some people through. So if everyone wants to have a look at that and take that down, reducemethuse@origin.org.au, pretty easy to remember. We'll have the recording up on our website, but also we'll have the flyers, and we can email those flyers out to participants in the audience too, if people are interested. So if there are no further questions, I might get everyone's interest in thanking Alex and Jill for presenting to us today about some really exciting research here in Melbourne. And if you're interested, please have a look at the website, and I'm happy to kind of follow up after this talk as well. Thank you for joining us today.